Good afternoon, and welcome to the Dental Community Resource. Welcome to our Tuesdays at 2 for our 7th webinar, focusing on topics that relate to emergency and urgent dental care during the time of the COVID pandemic, while we're under this state of emergency. I'd like to welcome those of you who are returning to our Tuesdays at 2, and welcome new members of the audience who aren't familiar with us. So we're a group of dentists who got together a year ago to set up a resource for dentists in our community and their team, focusing on information that is relevant to everyday practice. I'd like to thank members of our team who work behind the scenes, some of who you've met in this past year, who are instrumental in gathering and helping us synthesize information from one Tuesdays at 2 episode to the next. And this includes a broad number of clinicians as well as staff members who assist us. This past week has been quite overwhelming in the communication we've received from our colleagues in the community. Following our last webinar focusing on the RCDSO's guidelines on emergency and urgent dental care, there are lots of questions that related to items that were new to some, concepts that we hadn't considered in the past, such as PPE, engineering controls, and the cleaning and disinfecting of the operatories, depending on whether we just had an aerosol generating or non-aerosol generating procedure. To this end, we're trying to make sense of this all. Steve Minor and I and the rest of our faculty are not experts in this field, so we sought the opinion, the expertise of Dr. Kevin Katz. And today's webinar will focus on an interview that we conducted with Dr. Katz over the weekend. He has been very busy, understandably so, and was able to make himself available to us for a detailed interview focusing on these specific topics. Dr. Katz, some of you met last year at the DCR, is the Medical Director of Infection Prevention and Control at North York General Hospital. He's also the Medical Director of Shared Hospital Laboratories, Head of Microbiology at Sunnybrook Health Sciences Center, and the Chief Medical Officer of Practice Health Check Corporation. Dr. Katz was one of the founding faculty members of the DCR last April, where he spoke to us about infection control as it related to the new standards that new guidelines that were delivered to us. And then he returned in November to describe the anatomy of what a public health audit would look like. Kevin has been somebody we've consulted with throughout these past 7 weeks. And once he was able to make himself available, we actually were able to sit down virtually and conduct an interview with him. Steve, would you like to talk a little bit about Dr. Katz?
Good afternoon, everyone. After last week, there was so much unknown and uncertainty and controversy about engineering, about what the world might look like, that I think, the three of us sat down and thought and so many questions came from all of you and from us as well, to be honest. We all had questions about our own clinics, about what this meant and what this might mean. And we're getting conflicting information, especially now from all over the world, where, in Ontario, the recommendation was for 90 minutes or 3 hours, of downtime after use in a room. And then in other jurisdictions, 2 hours and then 15 minutes. And so much confusion, and to sort all that out, when we were talking about who would be the best person to help us answer, my relationship with Dr. Katz is not one of personal nature. A few years ago when we were building this clinic, I felt so overwhelmed and manipulated by industry, who I felt was opportunistic or trying to be opportunistic in my lack of knowledge and really fear of the IPAC regulations. When we approached Dr. Katz for advice, he answered us with facts, with real facts, good and bad, and with advice and very conservative mechanisms to keep our staff and our patients and ourselves safe. And I thought there's really nobody better in that regard to help us get through this next uncertainty or time of uncertainty. So I feel we're very fortunate to be able to have convince Kevin to sit down with us for a few hours on the weekend. And I think it's information that we really need to hear to help us understand what the future may or may not look like. Minor, what are your thoughts?
Yeah, thank you, and good afternoon, everyone. Thank you for joining us. I completely agree that IPAC issue that you bring up is a perfect example of how we may have forgotten, or we might remember very well, that just recently everyone was very frustrated or nervous or anxious about the whole IPAC regulations. And fast forward to today, and you know what? We got new regulations, and as with IPAC, as with now, I think the more we can share with you, good or bad news, things you may or may not want to hear, but the more we share with you as dear colleagues, the more you know, the less fear you have. And then having someone with the exceptional credentials like Kevin Katz is wonderful for us to know, and almost consider us, if I may say, us as wet finger dentists, John and Steve and myself, all with our own practices and our own staff and our own stresses to deal with during these difficult times, as you are dealing with. Consider us as the people who are almost like the friends that say, you know, you do have some greens between your teeth, versus the people who don't say a word and you walk around the whole day and you still have that green vegetable between your teeth and you say, God, I wish they told me something. Even if I didn't want to hear it, I wish they told me that. So please keep that in mind as you hear our presentation, as you hear this presentation, because there's some things you may want to hear, may not want to hear. And one last thing quickly is, also please keep in mind the very clear statement that the president of the Royal College of Dentists of Ontario made just about a week ago, saying, please do not go out there and start spending a fortune on, you know, all these things out there that we're bombarded with, as Steve was saying. It was a very clear statement. So we just want to educate you. The more you know, the less fear hopefully you have, and the more we can help you and one another move forward. John, I'll let you take over.
Thank you, guys. So with that as an introduction, here's our interview with Dr. Kevin Katz. Kevin, I'd like to welcome you. Nice to have you be part of this today. First question for you is how are you? How have things been going for you? And maybe you can briefly describe to our community how your life has changed in your role as Medical Director of Infection Prevention and Control since the province of Ontario declared a state of emergency.
It's definitely been a very busy time, pretty much from the beginning of January, when we saw what was evolving in Wuhan and Hubei province. It's been full on go, go, go. I think from honestly the second week in January through to last weekend, I don't think I had a single day off, and the days have been very long. So thanks for having me to this venue, and I'm part of the dental community resource. I'm sorry I couldn't join for calls prior to today. The acute care settings are settling down a little bit. The number of patients are, you know, persisting, but are coming down gradually. But just as that was happening, we got pulled in by the province to start helping in the long-term care setting, which is still a very, very severe situation. And so, yeah, it fit this conversation in because the dental community certainly will be ramping up shortly, and I'm sure there are lots and lots of questions.
You know, John, I'm thinking between Minor taking a few weeks off at the beginning and Kevin, you know, deciding that he's a little busy at this time. I'm glad that we're all able to get together.
Yeah, we've been in touch with Kevin consistently over these past few weeks, totally understanding how busy that you've been. What I'd like to zero in on, obviously, is the document I referenced earlier, the updated guidance on emergency and urgent care during the COVID pandemic, as it relates, obviously, specifically to the state of emergency that the province of Ontario is under. What we're going to talk about in today's Tuesdays at 2 are the guidelines that were provided and the new items that presented themselves in this document that we spoke about in great detail last week. We're going to focus primarily on the issue of aerosols, and we're going to revisit the scenarios that the college outlined for us. So, Kevin, my first question for you is this new item that we saw on the guideline, which is the reference to low-speed handpieces. Could you please expand on the need for dentists to avoid the use of low-speed handpieces?
Yeah. So the issue really centers around aerosol generating medical procedures, This has been a bugaboo going all the way back to the beginning in hospitals. You know, at the outset of the pandemic, the question was, is COVID-19 an airborne spread disease, or is it a droplet contact spread disease? And as you'll recall, the province of Ontario across all settings were recommending N95 masks because of the possibility that there's airborne transmission of the virus. Perhaps it's worthwhile just talking about the difference between droplet spread diseases and airborne spread diseases, just so that we're sort of setting the level and everyone's on the same page. There really are two main ways that these respiratory viruses can transmit. The first one is droplet-based disease, which is, these are larger droplets, and when you cough or sneeze or even speak, these droplets are larger in size and actually fall with gravity. And that's why everyone keeps on talking about 2 meters or 6 feet, because if there are droplets while you're speaking or coughing, generally they'll fall within 2 meters or 6 feet. And if that spatial separation is in place, then it prevents transmission. And for those kinds of diseases, the goal is to cover the mucous membranes with either a procedure or surgical mask. So it's not preventing the droplets from going around the mask, it's just catching them as they fall with gravity onto the mouth or nasal mucous membranes, and then also protecting the eye mucous membranes with goggles or a visor. The other end of the spectrum is airborne transmission, and there aren't many diseases which are spread by the airborne route, truly airborne route. These are things like chickenpox, varicella virus, or TB or measles, and those they're also droplets, but they're much smaller droplets. And essentially, the droplet can evaporate, and then the viral particles can actually sit on air currents and just stay suspended in the air for prolonged periods of time. And essentially, if you take measles, these airborne diseases are extremely contagious if you're susceptible. So people who are not measles immune, if you're just sharing the same airspace in a large, say 400 square foot room, if there's one measles positive case, just breathing the air, not even coughing, sneezing, just breathing the air, and there are other susceptibles, if you had 100 susceptible people who are non-immune, 18 of them would get measles just by breathing the same air. So highly contagious, and that's why measles is so highly contagious, because it's airborne. So for airborne diseases, the precautions are a little bit different. It's not just a procedure mask. It actually is an N95 respirator. And these respirators have a number of features: that they filter smaller particles with a higher efficiency, and they have a very tight seal around the outsides of the mask. And so it needs to be fitted to the individual. If it's a male, they have to have no facial hair, so it can have a tight fit. You may not fit all kinds of respirators, so I fit certain types, but I may not fit other types. Through my life, as I gain or lose weight, or my face changes, I may need to move from one respirator type to another. And then each and every time that you use that N95 respirator, you need to do a seal check to make sure that that seal around the outside is intact. So going back to the beginning, the province of Ontario and Quebec were recommending N95 respirators for all care of COVID positive patients. That has subsequently changed. They issued Directive 1 across the province in healthcare to say that now surgical or procedure masks are appropriate, but for aerosol generating medical procedures, they're still recommending an N95 mask with the other parts of droplet contact, so visors, gowns, and gloves. And the rationale for that they invoke is the precautionary principle, in that if there are aerosols and small droplets that can be transmitted and would get around regular surgical masks, that the N95 respirator would provide higher protection. So this is sort of the foundational background around the whole conversation. Similarly, in the United States, they had been recommending N95s. I think for all care, the World Health Organization has been recommending droplet masks or procedure masks for all routine care, but for aerosol generating medical procedures, again, N95s are invoked. In terms of what the list of things that are called aerosol generating medical procedures, the big ones haven't changed, but that whole list continues to be a conversation of what's on the list and what's not on the list. So for example, in hospitals, intubations are aerosol generating medical procedures. BiPAP and CPAP, positive pressure, would be considered aerosol generating medical procedures. Induced sputums and things like that. All of those are aerosol generating procedures. And then at the other extreme, there's, just routine care, people coughing, those would not be considered aerosol generating procedures. And then, everything under the sun, everyone wants to know, is it or is it not? So then you fast forward to this, that's a long-winded way to get to the question that you asked me. I think the high-speed handpieces are clearly a very high-risk issue. The low-speed handpieces, I think, is a question, and the college seems to be weighing in that it makes more sense to not use the low-speed handpieces because of the potential to generate aerosols. I think there may be additional evidence that will come out, but it will certainly take time for that to happen.
So Kevin, if I know that we've had lots of questions in the last couple of days, and just while we're on this handpiece and we can put it to bed, I've had people asking us, what about electric handpieces, which doesn't generate air behind it? What your opinion on whether that would be an aerosol procedure, or high speeds with no water? And I'll leave you to comment on these.
Yeah, so I mean, maybe we'll even zoom out a little bit. So it's actually the act of actually, the high speed actually sort of pushes or takes out pieces of tooth or enamel that's in contact with saliva. It's the contact with the saliva that's the issue. So I think the question that we should be asking, or the root of this is, well, what is the risk of the patient having COVID in their saliva to start with, right? That's pretty foundational to this, because if somebody doesn't have COVID and you know that for a fact, then there is not an issue. But the problem is, and in the early days this wasn't clear, but more data is coming out, is that people who clearly during the pandemic who have fever or who have cough and respiratory symptoms, the chance of them actually being COVID positive during a pandemic like this is reasonably high. The pretest probability is quite high. Initially, the feeling was if people are asymptomatic, that the risk is 0 or very low. And I think that was based on SARS, like SARS-CoV-1 back in 2003, when people had positive lab tests, they were sick. There was not asymptomatic people with the original SARS virus back in 2003. Similarly, with the Middle Eastern respiratory virus, which is another novel coronavirus, again, you tended to be symptomatic. With this virus, the issue is that you can be asymptomatic and be positive for the virus. And this is just question 1, but I feel like I'm rambling on a little bit, but it's important to understand all the different buckets. Oh, sorry, John.
No, please. I think this is a great foundation. Carry on, please.
So the asymptomatic is not one homogeneous group, right? There's asymptomatics that are pre-symptomatic, meaning that they're asymptomatic today, but in 2 days they may actually have symptomatic COVID. Then there's truly asymptomatics where they're lab positive and they never develop any symptoms at all, probably more common in kids. And then there's post-symptomatic. So somebody has COVID-19, they recover from COVID-19, but yet their lab test continues to be positive, either by a molecular test, which may or may not be contagious, or by viral culture, which most labs aren't doing because of the biosafety issues around it. So on the pre-symptomatic side, that clearly happens. So before you have symptoms, you can be contagious. I think that's part of the reason why it is so easily transmissible. And then also on the totally asymptomatic, where you don't even develop symptoms later, there clearly is some of that as well. Now, how common is that is a question. And there's a number of publications that are coming out that are shedding some light on that. For example, and and these are just different groups, but I don't think that there's any reason they're different between different populations. So I'll just name a couple of them, even though they don't relate to dentistry. There was a paper that was published out of New York City, reasonably close to the peak of their pandemic, and 12% of women who presented to the labor and delivery department for to deliver a baby, 12 to 14% of them were asymptomatically positive. A higher percentage of those that were presenting with symptoms, but they came in, all they were there for was to deliver a baby. They had no fever, no respiratory symptoms. Sort of 12 to 14% were positive. So that's not nothing. There have been other groups that have quoted also that 10% rate of 10% of all cases, not of all people, but of all lab positive COVID-19 are asymptomatic. We've done some surveys at our lab. We're one of the large testing labs in the city. And so we've done admission screens to our labor and delivery department, and we've found less than 2% positivity. We're doing admissions to our mental health units and have very low positivity rates. All of that to say, I think the percent positive of asymptomatics relates to obviously how much is circulating. If there's very few symptomatic cases, there's going to be less asymptomatic cases. But there's a lot of fear around the issue. And so people are very concerned that, yes, you can screen the day before the dental visit and say, do you have any fever? Are you feeling well? But if the answer is no, there is a percentage of people that will come through that could be lab test positive for COVID-19, may have COVID-19 in their saliva. And obviously, hands in the mouth and using these high-speed handpieces, low-speed handpieces, which are, really sort of spraying saliva together with enamel up in the air. That's sort of at the root of the concern.
Thank you, Kevin. We're going to switch now to the actual aerosol generating procedure and the PPE that was described in relation to that. We summarize this for procedures, emergency and urgent care procedures that cannot be managed without generating aerosol. The guidelines provided specific information. You've been very kind in dealing with the issue of fit-tested N95 masks. I know that Manor had a question for you with regards to N95 masks specifically.
Mm-hmm.
Yes, Dr. Katz, Kevin, if I may, thanks again for joining us. It's a huge, having you is really a huge benefit to our colleagues. In terms of the N95, there's so much buzz out there about with the aerosol producing procedures. How important is it, do you feel, just getting fitted? I already heard word on the street, people saying, well, I can't find one of these people to get fitted. And why should I bother? It's comfortable on my face. That's question number one. How significant? What do you comment about the fitting of N95? And the second question is about the whole issue about counterfeit N95. I know in the States, California, for instance, their whole message is not just shortage of PPEs, but the issue with counterfeit N95s, and then can use KN95s. So fitting of the mask, counterfeit masks, and KN95. Sorry, I know it's loaded, but this is, I know, a hot issue for dentists.
Yeah, those are all really important issues. And if I forget one of them, just please nudge me at the end. So the fitting, so there's two different pieces. Do some of the N95 mask designs fit better right off the bat on most people, on more people than some other ones? Definitely that's the case. There are some N95s that you could just pick up, and you know that when you actually fit test people, a higher proportion of them will fit test successfully into those, as opposed to, say, some of the cone-shaped ones that may or may not fit a face. So, some of the designs are easier to just say, yeah, that's likely to fit a large proportion of the population. But so that's just answering your direct question. Dentists are employers, right? And employers of small businesses. And as an owner of a small business, you have employees that you employ, obviously. And under the occupational health and safety legislation, and this is just my knowledge of the issue. I'm not sort of trying to, but your employees will be anxious, and so sometimes that leads to calls to the Ministry of Labor. And so the Ministry of Labor will want to know that if you're using the N95 masks, that they're being used correctly, because as an employer, you have responsibilities under that act. And as a supervisor, you have responsibilities under the act. Employees also have responsibilities under the act, specifically that they have to follow the instructions that you've given them and follow the training that you've provided. But the employers and the supervisors, you need to provide them with the right gear. You need to train them on how to use the gear appropriately. You need to provide a safe environment in terms of cleaning and the appropriate engineering controls and things like that if they're needed. So, to just simply provide an N95 mask and not have it be fit tested in the event that one of your staff were to become ill, I think the question would be, was that staff appropriately protected? And, I may view it one way, the Ministry of Labor may view it a different way after the fact. The hindsight's 2020. So, is it recommended? I would say yes, it's recommended to do the fit testing on the N95 and to have the sign off, just as I think it's recommended to have your staff trained in infection control procedures and to have an infection control manual and to have your audit office audited and have everything in place, just as we talked about back before the pandemic. These things are recommended, but the scrutiny will increase as safety becomes more of a focus. The issue.
No, and I totally understand that. Pardon me. Yeah, no, and this is a hot issue for dentists because it's so limited, which then, sorry, pardon me for cutting you off,
yeah.
But it also brings me then to the issue of the counterfeit ones, and everyone's saying, oh, I have a source that can get me KN95,
yeah.
Which, correct me if I'm wrong, the college says that during the pandemic or the state of emergency, we can use, and I'd like for you to comment on that too.
Yeah. So the issue of counterfeit masks and KN95s is certainly a hot topic. The KN95s, I don't think a KN95 is a KN95 is a KN95 either. So at the hospital, I've seen dozens of different designs and masks, and some of the KN95s, come with ear loops, and they're clearly not tightly sealing around the outside of the face. So there's N95s and N95s, and then there's KN95s and KN95s. And so, I know the CDC and others have said that KN95s may be a suitable alternative if you can't get N95s. But again, they need to actually work. And so we've put KN95s through fit tests, and they have failed at North York. So I think even more so, if you're going to use these things to prove that they actually pass the Vitrex fit testing, makes a lot of sense. The other hot topic, which you didn't ask about, which I don't know if we want to get into, you had one other topic, but is reprocessing of N95 masks is become a super hot topic. I'm happy to talk about it, but I'm certainly not here to endorse it because that's a clearly very off-label thing to do. But there is emerging literature around reprocessing of N95 masks, either with steam autoclaves or with STERRAD hydrogen peroxide vapor. And there's some data out of Winnipeg and National Microbiology Lab, and there's data coming out of the Netherlands and some out of the CDC. There's also UV light. There's a bunch of different ways to potentially do it, and that could be a whole long separate conversation.
Yeah, no, thank you for that. No, it's a whole issue, but yeah, we just want to try and concentrate on as much as we can.
Sure.
But that's a hot, and we know also that what you're stating is your opinion based on what you know now. Certainly in a week or weeks from now, everything may change. But no, thank you for that, John.
Yeah.
So Kevin, thank you. Many dentists have written in expressing their concern about using a face shield and then having loops. A lot of dentists practice with the use of magnification loops. Any advice that you can share how we can reconcile our ability to practice the way we're comfortable with using our loops and then a face shield on top?
Sorry, I'm just asking them to close a door so I don't hear a piano in the background.
That's okay.
So sorry, your question was around loops and then.
So the question is, yeah, and aphasia, because of just the logistics of being able to accommodate both. It's a question we've been asked a few times.
Yeah. So I don't, you're asking me and I don't have the actual document in front of me, but generally speaking, it's not a requirement absolutely in at least in the medical world. No one will say it needs to be a face shield. It typically is written as eye protection. And so eye protection can be goggles. They typically need to sort of seal or at least cover around the eyes, like just prescription lenses like mine, that would not be considered protective eyewear. So there definitely are hospitals caring for COVID positive patients that are using simple goggles and masks and not a face shield. The face shield is very appealing because it also covers the skin around the mask. And when we're doing aerosol generating medical procedures like intubations and some of these other procedures, which are closer to the conversation that we're having around handpieces and ultrasonic scaling and things like that, there is a concern around coverage of the skin around the face, not just the eyes and the mucous membranes, but also potentially lower down on the neck. So yeah, it's not an easy question. If you obviously need to be able to see, to be able to do the procedures properly. And similarly in the hospital around doing the intubations, the anesthetists are saying sometimes that they're having problems actually seeing and doing the intubations, which is not a good thing for the anesthetist and not a good thing for the patient. So I don't have a super easy answer about it, but I suspect the staff will feel more comfortable with face shields over the just goggles. The other thing that sometimes people do, which is not typically conventional, is to actually put a procedure mask with a built-in visor over the N95 mask. And I should mention the benefit of that, but also the benefit of the face shield is it protects the surface of the N95 mask. So the face shield protects the face and the skin, which I was talking about. But the other benefit of a face shield, or the approach of putting a surgical with the visor over it, perhaps it'll allow you to see through your loops better. It also protects the surface of the N95 to prevent it from getting contaminated by potential viral particles. And that can help to extend that N95 mask so that you can wear it all the way through to lunch or all the way through a longer period of time. Because if the N95 mask becomes contaminated, surface contaminated, it should be discarded. And we can talk more about it, but there is a document put out by the Centers for Disease Control in the United States. There's been a version of it out for probably more than a decade, so it's not just a new thing that was put out around prolonged use of N95 masks in a pandemic. It's classic part of pandemic planning. So I just say it's there for a long time so people don't think it's just being made up in the middle of the pandemic. It's been around for a long time. Prolonged use and then reuse of N95s. And so the criteria for actually doing that includes making sure that the mask doesn't get contaminated. And so the face shield or covering it up with a procedure mask with a built-in visor helps to keep that N95 clean on the surface, which given that everything's on allocation and back order, is an important issue. This pandemic is largely an exercise in supply management, actually, at least on the hospital side of things.
And we did reference that document a few weeks earlier, that CDC document regarding reuse and extended use. So we've had this discussion. Thank you.
One other question, Kevin, as it relates to the slide on the screen right now, is that these April 24th guidelines provided the first indication to dentists that the design of our existing operatories will need to be modified to have floor-to-ceiling walls and ideally, and I underscore that, a door. Would you kindly share with us the rationale, in your opinion, for these recommendations?
Yeah, so it is a bit funny to have the ideally a door. If you're arguing that you need floor-to-ceiling walls, it's because, I would assume, it's because they're trying to be able to create an environment in the operatory that is negative pressure to the hallway, potentially, or certainly if it's not negative pressure, to try to create a separate environment in the operatory from the hallway. And so in these airborne diseases, or diseases that you're, based on the precautionary principle, trying to treat as an airborne disease, generally what would be recommended is to have high numbers of air exchanges in the room. And then the second piece would be to create a negative pressure between the operatory and the hallway, so that to achieve that, and it's less typical in a dental operatory to talk about it, but in a hospital room, which is where we tend to have these airborne isolation infection rooms, AIIRs, essentially there's a door, and the door has to have sweeps on it, not sealed, but sweeps, so that it can pull air through the outside margin of the door. And you actually can have transducers which measure the pressure differential between the hallway and the room. And you need to have a negative pressure differential. You can test it with a smoke test, where you go by the edge of the door and sort of release some smoke, and it pulls into the room. And essentially all of the exhaust is out through the bathroom, and the bathroom door is left open. So the flow of air is from the hallway into the room and out the washroom. If, you know, what the College of Dental Surgeons of Ontario is saying, floor-to-ceiling walls and ideally a door, they haven't talked about negative pressure, but they clearly are trying to keep aerosols in the room, because another part of the document talks about washout periods. And so, so the ideally a door part makes me smile. I think they would want floor-to-ceiling walls and a door with potentially sweeps, so that you would keep aerosols in the room and keep it out of the hallway. Do you have the question around the washout separately, or is it?
Yeah, well, yeah. So I'm going to jump in here if I can. I know a hot topic is certainly the 3-hour washout period, and people are wondering. And I'm going to ask you a couple questions regarding that, because I know this is. First of all, it was our understanding, and again, we were just trying to, that without really understanding the engineering in each individual environment, that 3 hours was probably a safe decision to make, that without further investigating engineering, trying to keep most people safe, and that's where the 3 hours came from. Is that your understanding as well?
Yeah, 3 hours is definitely on the long side. Presumably that what they're trying to do is to have all of the air in the room exchanged before somebody goes into the room. So we typically talk about washout periods in the hospital, where we have people who are in the room, say with measles or with tuberculosis, and let's say we discharge the patient, or they go out of the room, and we want to have that room cleaned by an environmental cleaner. And the question is, does the environmental cleaner or the person going in that room have to wear the airborne protection, like the N95 mask, or can they go in without? And so the washout period comes into play. And so the time is directly related to the number of air exchanges in the room. And so I know in the hospital environment, we measure air exchanges across the facility every 6 months. So we actually know which parts of the hospital have how many air exchanges. And there are Canadian Standards Association recommendations for old buildings and new construction in terms of how many air exchanges and how all of those HVAC systems are supposed to be designed. But if you have 0 air exchanges, let's say it's a very, very old facility, and you have, you know, radiators for heating, and there's actually no HVAC system other than that, obviously that will take a really, really long time to exchange the air in that room. If you have, you know, standard air exchanges, let's say a 4 to 6 air exchanges an hour, there are tables, you can look it up. I don't know them all off by heart for all of the different levels. I sort of have some in my brain, but that may take, you know, a couple of hours until that air is completely exchanged. And it depends whether you want to exchange 99% of the air, or whether you want to exchange 99.9% of the air. And so the higher the air exchanges, the less time you need to filter out the air. And so I was just looking at the tables a few days ago. If you have 20 air exchanges, and to get 20 air exchanges, you actually need quite an HVAC system to achieve it. And that HVAC system will consume quite a bit of power and energy over time. But if you do have 20 air exchanges, to filter out 99.9% of the air, or to exchange 99% of the air in the room, it's in the order of 21 minutes. So you can see going from 0 to 20 air exchanges, there's a huge difference. So I do think that engineering controls are going to start to come into play. And, there's the components are the negative pressure to the hallway, which involves door sweeps, and you can't get negative pressure if you're not going up to the ceiling, right? If you have open walls, you're never going to get negative pressure. It's impossible. And then the number of air exchanges, how that air is being exhausted. A lot of dental offices, I'm sure, exhaust into the plenum. The plenum is that space above the false ceiling, and it probably needs to be exchanged out through the sanitary exhaust. So, I think each office, if you're looking at these things, each office will be a little bit different. There always are exhausts that are straight out through the washroom. So if your operatories are close to the washrooms, it's probably easier to tie into that. I'm not an engineer, but actually the colleague Maya that I work with knows. I know a working knowledge of it. She probably knows more than I do about it. And HVAC engineers, healthcare HVAC engineers, this is what they do.
So,
if I may.
So Kevin, the big concern is as we're going forward, you can foresee, and again, I know you don't have any early access to the guidelines or the documents that are coming, but you can foresee that 3-hour period will be reduced depending on the different engineering that you can supply for your environment. That's something that we're probably looking for. And just to put people at ease a little bit, we were speaking a little bit before that if it's really marked from the time of the last generating aerosol procedure, not from the end of the appointment. So now things start to play in and become more reasonable if you start looking forward.
Yeah. So the RCDSO hasn't exactly explicitly said why. I think eventually they will have to say it's because of this principle. And once you have the principle clear, then certainly that's what my hospital pays me to do, is to make those risk decisions for them, and to come in and say, okay, the washout period in this environment based on the assessment of this operatory can be this number of minutes. And yes, it's from the time of, in this case, it would be from the time of the end of the aerosol generating medical procedure. For somebody with measles, that would be the last moment that person is in the room. But for dentistry and for what we're talking about in COVID, it would be from the time that handpiece, high-speed handpiece would have ended. So if the patient has the rest of their appointment for another 10 minutes, and then you turn the room over and clean the environment, and you have 20 air exchanges, then you could probably almost bring the next person in straight away. That would be my opinion. And I'd be happy to engage the College of Dental Surgeons to have a conversation with them if they wanted an expert opinion on it.
So that concludes part one of our interview with Dr. Katz. Obviously, there's a lot of information there. And before we delve into that, as well as the second part of the interview, I just want to circle back to some housekeeping issues that also came up during this past week. We've had lots of requests and information about regarding group practice of PPE. We appreciate the suggestions, the effort, the availability. A lot of you have made yourself to help us with this. At this time, we continue to look into this and investigate the process. Our biggest concern, obviously, is in our ability to vet products as they come to market. The second housekeeping issue deals with mask fitting, particularly that of N95. And we have indeed identified a vendor who can help us with the fitting, except that they do not have masks because obviously they're such demand and so are not readily available. If you continue to have an interest and have masks available, we'll be very happy to coordinate another event for mask fitting for you. With that, I'll pass on the floor to Steve.
Yes, thanks, John. I think as I'm sitting here listening to this interview, there's a lot to take in, and some of it is even overwhelming. I'm trying to make sense of how there can be conflicting guidelines in other areas that seem to disregard this kind of science or not take it into account at this point. And I'm still hopeful, very hopeful, that there'll be other remedies for this aerosol solution, like high volume suctions, like other remedies that are easier and more affordable for us, that doesn't require such major changes to our engineering. I'm interested to hear the second half and if there's any more clarifications, but I do appreciate understanding it at a different level. And now I'm really confused as to how it can be so different all over. So we have to really just stay in our lane a little bit. Minor, your comments?
Yeah, thank you, Steve. No, just sort of recap even part one, you may have heard things like I was saying in the beginning, you may or may not want to hear, but I remember the days of IPAC. There are a lot of things we did and didn't want to hear, but it's just nice to please look at it in a way where the more you know, the more you can prepare for moving forward with your practice. Not that anything is etched in stone, and do remember that also, just as the statement again from the college was, don't go out there and start buying stuff and making major changes unless it's absolutely mandated. So sort of we hope that as you saw part one, and as we hope you join us for part two on our YouTube channel, that you keep in mind that while you may not hear things you want to hear, it's all about the more you know, the more you can start to plan to move forward with that cautious optimism. We're here to relay information, to answer the questions that you guys and ladies are giving us, and to just help one another. So I do hope you'll join us for part two, where Dr. Katz talks more about things that will hopefully help with our anxiety nowadays, and including the widely spread petition that's being circulated, more about PPEs and whatnot. So we do hope you'll join us for part two. Thank you.